Welcome to Deuk Spine Institute's live stream of spine surgery on Thursday, August 10th, 2023. This patient comes to us from
He's from
Pennsylvania. Yeah, Pennsylvania. And his story is so sad. You're going to hear from him tomorrow. When he does his testimonial tomorrow, we get it published. But just the typical horror stories of people with back pain, multiple laminectomies, I think 4 or 5 of them now, and fusion, you could see it on the x-ray, and basically still in pain, finally decided, come to Deuk Spine Institute, get fixed properly. And so he's here. We're going to fix 2 herniated discs. The left L4-5 disc herniation happens to be right in the foramen, in the neuroforamen, pushing against his nerve root. So it's really bad. And then on the right side, he's got an L3-4 herniation. You can see I'm directing the needle to the herniated disc. Right above his fusion. And you can see the hardware there, right, Henry? Jordan, you want to show us the screws and rods? For those people who have never seen hardware, there's screws, rods, and then show us the cage in between the bones. This is just horrible, folks. People are getting fused left and right, and the fusions just create more problems, obviously. And so they're getting more surgeries and still in pain. And finally, they come to Deuk Spine where we can help them. All right, AP, we're going to use x-rays to navigate 2 needles into 2 discs. On the left side at 4-5 and the right side at 3-4. This patient has bad stenosis with nerve root compression. That looks really good. So you can see people get adjacent segment disease, which means the area above or below their fusion, and they get pain in those joints because those joints end up wearing down very quickly. That's what's happening to him. He's worn down those joints. All right, so I have to keep redirecting. Just about there. I'm getting around his facet, and it's full of arthritis. I can feel it. Now the surgery you're watching, the Deuk laser disc repair, is endoscopic, minimally invasive, outpatient. It literally takes 1 hour to do. Is he reliable?
How are you doing, my friend? You okay? He said yes.
All right, good.
He said yes. Okay.
We're at the 4-5. We're going to get into that disc right now. Any questions from the audience so far?
No current questions.
You can see the needle going into the disc. His spine is quite anterior. I know that because, look, the needle is sunk all the way down to the hilt. These needles are all the same size, and the fact that it's sunk all the way to the hilt means his spine is very deep inside his body, like very far forward. See how long the needle is? So we're going through a hole in the side of the spine called the neuroforamen. Next, we're going to go from the right side, and we're going to do the next disc, which is the L3-4. So he's got 2 herniated discs with narrowing or stenosis, L3-4, L4-5. Let's run the video showing how is it that these herniated discs can cause so much symptoms. Our patient is resting very comfortably. He's not asleep yet, he's awake, but we need him to participate. All right, I probably want to start a little bit lower. We've numbed up his skin here, so it's helping a little bit. I feel all the arthritis right there from the facet joint. I'm going to start a little bit lower. Yeah, you're doing great. Just lay still. So you can see where I'm aiming for is that L3-4 disc. Yes, thanks, Jordan. So these are directional needles. By the way, I'm feeling a lot of arthritis in the facets. There we go. I felt the herniation right there. AP, I'm going to check a front view. We've been using the side view. So far, we've lost about 2 or 3 drops of blood, that's all. You don't lose much blood with this surgery. That looks perfect. You see he has a little bit of scoliosis. You can also see they did laminectomies on him. Show us the laminectomies, Jordan. Look at the spinous process up above at L2, right there. And then it's missing there, it's missing there, it's missing there. So all the surgeons were doing in Philadelphia or Pittsburgh, they were just doing more surgery so that they could create more surgery. In other words, by doing laminectomies, they weaken the spine, cause scoliosis to happen, and they end up doing more fusions. Every couple of years doing another fusion. That's how they make their money. And patients are just taken advantage of. All right, look at that. That's interesting. So you can see this needle is longer here. So the spine is curved. It's curved more towards the right side where we're going in. I'm ready for him. Now he's having horrible back pain. Yeah. That's fine. He also had piriformis pain when I saw him. He had trochanteric bursa pain, and he had iliotibial band pain down his leg. He also has radiculopathy, which is a pinched nerve with weakness, numbness. But he also had pain right above his fusion, right in this area. And there are 2 discs here that are damaged. Remember, his fusion is at L5-S1. And he's got the cage in there. We're not going to mess with that, but we are going to fix L3-4 and L4-5. You comfy? Yeah. All right. You can hear him say yes. How bad is that on a scale of 1 to 10? How high does it go?
What number? 8 or 9?
9. Is that where you get back pain? Oh, 9 out of 10, concordant at L4-5. Is it better now? Show us the tear, Jordan, on the lateral view. Henry, go to the lateral view, X-ray. You can see the tear right there in the back of the disc. That's the annular tear. It's around 2 centimeters from inside to out, 2 centimeters long. Is it better? No more pain? Can you guys hear his responses? You hear him tighten up. How high did it go? 10. He said a 10. So the L3-4 is a 10 out of 10. Is that where you get back pain? Style it. All right. We're going to put you to sleep. When you wake up, all that pain will be gone. Isn't that wonderful? Right? All right. You've already ran the educational video or no?
Not yet.
Thanks. All right, so I made an incision. Now we're going to bring our dilator down, and our patient is going to sleep. As we bring the dilator down, there'll be some numbing medicine put in. To help numb up the muscle and fascia, the pain-sensitive structures. Shot. All right, you can see the tip of the dilator heading towards the L4-5 disc and foramen. Show us, Jordan, take a shot. Show us the foramen, the neuroforamen on the side of the spine. There you go. How do you find the neuroforamen? It's between the pedicles. Where's the pedicle? There and there. That screw is in the pedicle of L5. All right, very good. So we're heading down to the disc. Our patient is going to sleep with propofol. And really no bleeding during the surgery. No scar tissue, no bleeding. Shot. All right, just about there. I'm navigating the arthritis in the foramen. Notice I don't hit my dilator hard, okay? I do it gently. Why? Because there's so much bone in that area that if I hit it hard, you might just like fracture off pieces of bone, or you may end up going somewhere you don't want to go. So by letting it gently follow the guide wire right to the disc herniation, which is where we are now, now I can take the guide wire out and I can enter the disc properly. I felt the tear, I went through it. Whoa, let's show the audience. If you've not seen this before, we're doing the whole surgery through this tube. It's a 7 millimeter tube. Any questions?
No current questions, but we do have a comment from Sunil on Facebook.
Hello, Sunil.
They said, this patient finally coming to their destination.
Yes.
Great, Dr. Deuk and his team. Anyways, Dr. Deuk's voice is different today. Hope he's feeling good.
Ah, Sunil, you're very perceptive. That means Henry's doing a good job with the audio. You're correct. I am sick. I have a flu, cold, for the last 2 days. And I've not been feeling well, but I don't want to disappoint my patients and not come to work. So these people come from far away, and I'm not going to cancel their surgery just because I don't feel well. It's part of being professionalism, doing what you're supposed to do when you're supposed to do it. My team is a professional team, and I'm a professional doctor. So we would never want to disappoint him and his family and make them have to come again. So I would rather be home. You're right. I mean, resting, but I love what I do as well, so that helps get me through the day. But thank you, Sunil. You're right. I'm very nasally. I didn't sleep at all last night. I already feel better, though, so thank you. Okay, so for those of you who've never seen this before, the tube, the end of the tube right there, you can see the end of the tube. That is inside the herniation and annular tear. And now you can see the tear. I'll show you with the laser fiber. There is the tear and the herniation. It's staining a faint blue. Now for reference, for those of you who've never seen before, the fiber is 1 millimeter side to side. So you can see how big the tube is. It's around 5.5 millimeters. So this is not big. A lot of people say to me, but if you're removing the disc, won't that harm, the disc and then you have to fuse? No, we're not doing anything to the normal part of the disc. We're only treating the herniation and the annular tear, which is the source of the patient's symptoms. Thank you. All right, we did the video on how a disc tear, annular tear causes back pain, right?
Not yet.
No, we haven't. All right, let's go ahead and play the first educational animation. Thank you, Sanjay. Welcome back. Understood. So there's two sources of oxygen then. One is the tube that puts pressure, right? It pumps air from the operating room, and the other.
We're putting air from our oxygen machine into the.
Oh, so you connect the circuit to the anesthesia machine, not the CPAP machine.
The oxygen is connected actually to the CPAP tube. Yes. Yeah. The tubing.
All right, I gotta look at it.
It's hard to explain.
Well, there's two sources of air.
Nasal cannula oxygen, which is connected to the anesthesia machine here.
Right, which comes from our medical gases.
Correct. There's flow meters that connect to a valve, a nipple valve.
Yeah.
That goes right into the mask.
So that's not a CPAP machine.
That's on
It is on a CPAP. But you're saying the CPAP machine of the anesthesia cart or a different CPAP machine?
No, that CPAP machine is an individual one.
Where is it?
It's right behind my foot.
And that connects to the fat tube.
Yes.
Yes, exactly.
So you are connected to the CPAP machine. It's not all done through the anesthesia machine.
The only he's only providing
Oxygen
oxygen.
delivery is
That's
from
it.
Yeah.
the anesthesia machine,
But there's also oxygen delivery from the CPAP machine, right? Through air, room air.
yes.
Yeah.
That's correct.
Yeah, it's pressurized.
That's correct.
And it's mixing with the oxygen.
You're getting 21%, we're giving 100% from the anesthesia machine.
Yeah. Oh, is it? Yeah, it's 100. Yeah. So it's a combination of 21 under pressure plus 100 that monitors the CO2. All right, sorry, we're just having a discussion about what we're doing, you know, on the anesthesia side. Any questions from our audience? So right now I'm doing the
No
debridement.
current questions.
This is the Deuk laser disc repair. This is called the annular debridement. People ask me, are you doing a discectomy? No, we're not doing a discectomy. Discectomy is where you take out the disc. They're asking me, are you doing a herniectomy? No, we're not just doing a herniectomy, because a herniectomy, you take out the herniation only. We're actually debriding the annular tear. You can see there's more than a herniation. There's this gold stuff, that's calcium, dystrophic calcification. There's annular fibers that we're debriding, torn. So that's not the hernia. The hernia is nucleus pulposus. So technically we're not just removing the we're not removing just disc or hernia. We're removing more than that. We're removing inflammatory tissue. See, if I don't remove this right here with the laser, the disc will not heal properly. And then my surgery will be not much better than other surgery like microdiscectomy. So the debridement is the key to getting the disc to heal properly. So your risk of reherniation goes down. What's interesting is we've had virtually zero reherniation in the last 2 years, mostly because of improvements in instructions for the patients postoperatively. All right, let's show the video, Sanjay, on how the Deuk laser disc repair works. Welcome back. Now you understand how the Deuk laser disc repair works. We're using the laser to debride the annular tear that causes the pain. The annular tear is a source of pain, and it has to be cleaned out, debrided. Just about done. You can see the end plates. So it's kind of an interesting, we're at the back of the disc, you see the fat there and a little vein. The laser fiber is 1 millimeter across. This is the lateral herniation. You see how the herniation is scarred right there? That surface is scar tissue. The blue is herniation. So because it's blue, I know there's nucleus pulposus. The nucleus pulposus is the only thing that stains blue. Nothing else will. The blue is a vital dye we inject into the disc during the discogram, and it only binds to degenerated nucleus pulposus. So if there's no herniated disc, you won't see blue. I heard Elon Musk has back pain as well as neck pain. He needs to come here so we can fix him properly. You're going to send him something? You should. We can help him. 100%. Huh? You're friends with Elon Musk. On Facebook. Well, do it. Get it done before he goes and does something stupid, like getting a laminectomy.
I'm also with his fan club.
Are you? Nice. I like him.
Yeah, I do too.
I don't know him personally, but
I've never done
I like the fact that he's pioneering things, trying to make the world hopefully a better place. You never know what people's true intentions are, but all right, just about done. You can see the fat at 12 o'clock, the veins all there. There's a nerve there. You see that? Oh, that's beautiful. Look just inside that as it moves, just deep inside. You can almost imagine a vein deep inside on top of the nerve root. That nerve root is called the traversing root, and that in this case would be L5. You see how close it is to where the herniation was. So now the exiting root is above us. It's in a little different position. If the traversing root's at noon, that's the traversing root. The exiting root will be up there. There you can almost make it out, but it's in the fat. So we're done.
Lights on, please. Thank you.
This is left L4-5. Next will be right L3-4. Everyone agree? Right L3-4. We'll use a little antiseptic. Any questions from the audience?
Yes, we have a question from Canes25 on YouTube.
Yeah.
And they said, I thought you, they just, well, it's also to be aware of just that our sound is off when we play the animation videos.
Oh, yeah. Oh, good. I'm glad you did that.
Yes, yes. I thought you don't mind me answering this.
Why
for
don't
Canes.
you tell everyone why we turn the sound off now?
So the reason why our sound is off for the animations is that when the animator who made it had a song that is a song that we can't use for copyright issues, and so for that being is that we.
Well, we can use it, right? I thought we're allowed to.
No. We can use the video itself. It's the music that is playing. I didn't specify on that. It's the music that is playing in the background that for some reason YouTube doesn't like us for
Well,
that.
yeah, but we did pay for the use of that music when we used it for the video.
I believe so.
Yeah.
I think, I don't know if it had an expiration date or anything like that, but I'm sure it's 100% solvable. That's for sure.
Right, but when YouTube sends us a copyright email that your video is flagged for copyright for that song, don't you dispute it, right?
Every time.
And we win every time, right?
Every time.
That's because when we made the video with that music, we had the right to use the music.
Yes.
So it's just what happens is if we play the music and the sound of that animation video, we keep getting, flagged for copyright, even though we haven't done any copyright violation. All we got to do is dispute it, and then they release it. But it's a pain in the ass because we've got better things to do than to keep having to do disputes.
100% correct.
So we just said the heck with it. Let's just take the sound off.
You still see the idea of it there, and you'll still see the subtitles. But given that, this should be solvable one way or another.
Do we inject?
And on top of that, we do have a question.
Yeah, sure.
This comes from Tom on YouTube.
Another incision on the right side.
And
Tom on YouTube.
Tom asked, what's the difference between a laminectomy and a discectomy?
That's a great question. A laminectomy, by the way, our new website, which will be launched in a few months, is going to show you all of these things. And it's going to become crystal clear. But for now, a laminectomy is where, I have to cut that, is where we remove the bones and ligaments in the back of the spine. It's an old procedure. It's been around for 100 years. It used to be the best surgery we could do, 100 years ago. But since then, we've developed better technology like Deuk laser disc repair, the most advanced. So I don't have to remove any bones or ligaments or muscles from the spine, in the back of the spine. Other surgeons are still doing laminectomy, and they're taking the bones and ligaments out the back of the spine. Their goal is to try to unpinch the nerve from the back. The problem is the nerve is being pinched from the front by the herniation in front of the nerve. Show us, see where the tip of the dilator is? There's a herniation there. You guys can see it. It's bulging out there, yeah. That is the herniation. The nerve is just above it, right there. So the herniation is bulging out, hitting the nerve. We're going to go in and remove the herniation. That's what you should do. But other doctors come in through the back, and Jordan will show you with the mouse. They come in through the back, peel all the muscle off the spine, and then they drill that bone away right there. That's the pedicle, down a little lower. Go to show the bone. They drill that bone right there. All that bone, they take it away. And then the nerve is, indirectly unpinched. It's a horrible surgery. It's just the wrong way to do it, but doctors don't know how to do the new stuff. They're taught the old stuff. Now, there is a financial reason to do the laminectomy, and that is that it always leads to instability, which then leads to more surgery and pain management. So there's a lot of money being exchanged hands when you do laminectomy. The patient's basically going to be having years of pain management, pills, and all those doctor visits make money for the medical system. And then the end game is that what you see below. Show them the hardware. You end up getting a fusion. So this patient ended up going back to his doctors in Pittsburgh, and they said, yeah, it's time to do another fusion. And he's like, the hell with this. Let's find a better way, because this was his 5th surgery that he had had. So they just keep doing more and more treatments and more surgery, and they keep racking up more and more bills. Nothing wrong with doctors getting paid for their services and hospitals or whatever. But we should be doing what's in the best interest of the patient, not what's in the best interest financially of doctors, implant companies, and hospitals, and insurance companies. We should do what's best for the patient. And that's why when you do a laminectomy, you're destroying the spine. Now, when you do a microdiscectomy, you're doing the laminectomy to get to the disc, and then you're trying to pick out pieces of the disc. So, but it doesn't work because you're literally reaching in a dark hole trying to grab little pieces of herniation. Now, you've seen me use the grabber. It doesn't grab the herniation. It slips out of it. So that's the problem with microdiscectomy, is it doesn't properly remove the herniation, and it doesn't debride the annular tear. There's no debridement. So microdiscectomy is a laminectomy and a partial facetectomy. It destabilizes the spine, but it also adds in a discectomy where you're grabbing and trying to pull out pieces of herniation in front of the nerve root. They're all bad surgeries. Microdiscectomy is a little better because it's trying to get the herniation out. But they're both like 100-year-old surgeries that there's vastly better treatments now. The Deuk laser disc repair. They just cause too much collateral damage, and they don't directly address the pathology, as we say. So that's why people still have pain and symptoms. That's why they keep getting more treatments, like this patient. The treatments just never end. We don't want patients coming back after our treatment. We want them done. Now, patients do come back about 10% because they have a different problem that they didn't have or we didn't treat the first time. And that does happen. But patients never come back here for treatment of the same problem that we already treated. In other words, there's a herniation. If we do the Deuk laser disc repair at L4-5, people never come back and get another Deuk laser disc repair or fusion or anything at L4-5. Why? Because the Deuk laser disc repair worked. Now, when you get a laminectomy, this is a huge herniation. This is going to be a big one if I can get it. But see, it's so big, it's like sucking against the walls. All right, I got part of it. Let's see, there's some more. See, I told you it broke in half. Maybe not even half, maybe thirds or something. That thing's huge. And it's got sticking to the walls is so big. Oh yeah, it's gonna be big. There it is. All right, let's turn the light on just for fun. Show everybody. Patient will want to see it. There's the second piece. Where's the other one? Can you see the tape measure? Uh-huh. Yeah. So that's a herniation. See now, see this, guys? This thing's huge. Okay? But most of the time, herniations aren't just one big piece or two pieces. Oh, there's another one. There's some more. So it's usually a bunch of pieces. And in his case, so far, we got 3 good-sized pieces. But some of that's because I ripped it, you know? But I'll tell you, usually it's around 30 pieces of herniation. All right, that looks much better. Yeah. Another big piece. Not as big as the last one, but good size. Lots of pieces. So what does that mean? Well, it's important for people to understand a herniation is not a one-time event. It's not like you get an annular tear and then a herniation and you're done. And that just stays there. What happens is people just keep herniating the rest of their life until the tear is repaired with Deuk laser disc repair, or they get a fusion or artificial disc. Only then, when you actually remove the whole disc, does the herniation stop. Now with the Deuk laser disc repair, we clean the tear so it heals, and then you don't get any more herniation. That's one of the advantages of our treatment, is healing the tear so no more herniation comes. All right, any questions?
Yes, we have a question from Edward.
Hello, Edward.
He says, "Hi doctor, I'm a few weeks DLDR post-op.
Ah,
I've been getting burning in my forearm, triceps and armpits.
uh-huh.
Is this an indication of the nerves healing?"
Is that an indication of the nerves healing? Well, first of all, I don't ever discuss patient stuff over the public space. So I can't address you specifically, but if you've had surgery, there's lots of reasons why you could have some burning. It could be that you have a pinched nerve in your arm, like carpal tunnel syndrome or ulnar neuropathy. It could be bursitis. It could be bicipital tendonitis, deltoid tendonitis, rotator cuff, but generally it's never due to the nerve. It's very rare. Now, in the first 2 weeks, it can be from the nerve. We call it nerve root regeneration pain. So I would need a lot more information to tell you why you're having burning. But I've never seen it from the nerves that we treat except for the first 2 weeks as they're healing. And I don't know your history, and I don't want to know it. If you have questions, contact Sam and set up a telemed. But, you know, publicly discussing your medical care is not something I can do. There's laws against it if you're my patient. If you're just asking general questions, it's fine. But I don't want to be talking about a specific patient's care in front of the public. It's just not appropriate. So, yeah. Contact Sam. Sam is who set up your MRI review, and we can do a telemed. You can actually do it today if you have time. And then I could look at you and see what's going on. A lot of people think that diagnoses can be made over a report of an MRI or by just saying, hey, here's my symptoms. It cannot. You have to do an exam. A physical exam is very important. I don't make any diagnosis without a physical exam. And a physical exam can be done on virtually through a video conference with a patient. You can actually do an exam. I use the patient's own hands to touch things. I use the patient's to mark out where their pain's coming from. But I do not just make a diagnosis based on symptoms. It's not possible. You're going to make the wrong diagnosis. All right, any other questions?
Yes, doctor. We have a question from Vizi or Vizi on YouTube.
Uh-huh.
He says, hi doc, could you please speak on
Grab it.
lateral disc bulge narrowing the foraminal space with L4 nerve root contact?
I couldn't really hear what you said, Sanjay. You did a pretty good job. Try to enunciate a little bit more. Something about a nerve root at L4-5?
Okay. Could you please speak on lateral disc bulge narrowing the foraminal space with L4 nerve root contact?
Without. Oh, yeah. So, folks, you don't need to have nerve root contact on the MRI to have nerve root findings or symptoms. The MRI is not sensitive enough. Most of the symptoms are due to inflammation. You don't need contact to have inflammatory symptoms. The whole world has been mistaught. They're being taught that you need a big herniation crushing the nerve root to have symptoms. That's a lie. 95% of nerve root symptoms don't come from contact. They come from inflammation without contact. That's why you're having symptoms. You have inflammation from the disc tear getting on your nerve root. It still needs the Deuk laser disc repair. This treatment you're seeing right now is the treatment for it. Nothing else will work. All right, good questions so far. We're just about done. And I come and answer your questions face to face. So type your questions up because we are finished. That's nice. Very nice. This is the disc we took all the big pieces out, right?
Yes, sir.
3, 4.
Oh, yes, sir.
All right, you ready, Berndes? I'm done.
Okay.
You're welcome. A lot of scar tissue from inflammation. Nope, we're done.
Lights on, please.
The nerve is up there. You can see it right there. There's a vein on top, and the nerve is running right there. Let me get just a little bit right there. There's a little bit of herniation below the nerve right here. Not much. All done. All right, very good. Great job, everyone. Yeah, I noticed he hasn't moved. Seems very comfortable. All right, let's show the audience the incision that we have. We have one on the left side and one on the right side. You can see the one here on the patient's left. You see how small it is, Henry?
Yes, we do.
It's about 8 millimeters. So these are Band-Aid incisions. That's what endoscopic surgery is, Band-Aid type surgery. And the patient will go home in an hour. Of course, he's not going to go to Pittsburgh in an hour. He'll go to Pittsburgh tomorrow. But they go back to their hotel, spend the night. He'll be up walking around this afternoon. Now, I will say one more thing. And I mentioned it earlier, like many patients with disc problems, he had other problems as well. He had piriformis, trochanteric bursitis, iliotibial band syndrome, bilateral sacroiliac joint inflammation, and then he had the 2 herniated discs. So he has not had his SI joints treated yet. We're going to do that, I think, next week when Dr. Patel arrives. He's on vacation. I don't typically do the SI joint Deuk plasma rhizotomy. I can, but I think Dr. Patel does a better job than me, and I like the patients to have the very best. So he's got everything except his SI joints treated at this point. All right, write up your questions, and we'll see you in a few minutes. Oh, yeah. I'm Dr. Deuk at the Deuk Spine Institute, here with a patient from Virginia who came out to the Deuk Spine Institute yesterday for surgery, and we fixed 2 discs in his lower back. You were having back pain for some time. Do you still have that same back pain?
No.
Gone.
I feel my back feels 100% this morning. I was able to sleep in the bed, laying flat for the first time in 2 months. I was sleeping on the couch for those 2 months, and I did not get good sleep at all. So I feel great in my back.
Good. Well, that's why we're here. We wanted to cure your back pain and give you quality of life back. What was life like living with that back pain?
Any day you'd be like, it could happen today. I could go down with back pain, severe back pain for a week. And that happened. My first pain started about 5 years ago. I was working in the flower garden. I went down with severe pain. I was down for probably a month that time. And ever since then, it was just like randomly, just out of the blue, I'd go down for another week with severe back pain. It was just no way to live because I knew every day waking up it could happen today.
Yeah, it is no way to live because then you got to be careful every day. You don't set it off. You're worried about it. You're thinking about it. It takes control of your whole life, that back pain. His back pain happened to be coming from 2 discs. And did you see any other doctors? Did they recommend treatment for you in Virginia?
Yes, I was seeing chiropractors for the first number of years. The first chiropractor, he put me on this decompression table, and he would, pull you apart. I did that for 6 weeks. I felt a little relief at first, but it didn't last very long. And I've been seeing just regular chiropractors throughout the years as well. And then when this happened, I saw an ortho doctor. He did not recommend surgery. He recommended physical therapy. He said surgery is like a coin toss. It either works or it doesn't. And that was not good enough for me. I needed a little bit more reassurance that it's going to work. That's when I started looking for other options. And I had a lot of time on my hands. I did a lot of research and I found Dr. Deuk here. And I started watching his videos and testimonials. Made up my mind right there. It was without a doubt. That was my choice right there. I submitted my MRIs, and within 2 days, I did my virtual consultation with you. And 10 days later, I'm here.
Yeah.
And It's amazing. I had an appointment with an orthopedic doctor in Charlottesville, and that was February the 2nd for my first visit, just for a consultation. And who knows how long it would have gone after that.
Years.
And yes, I'm done now. It's just I'm back to recovery.
Yeah, the problem is, unfortunately, the vast majority of doctors treating back pain don't know how to cure it. They just don't. And if I had to put a number on it, I'd say 99% do not know how to cure back pain. It really comes down to two things. You have to make the right diagnosis. Where is the pain coming from? Most doctors really don't even know it comes from the disc, and that's where it comes from about 90% of the time. Then the second problem is knowing how to treat it. And the treatment that works, the only treatment that works, is surgery on the herniation, really. And there's two surgeries that work, fusion and the Deuk laser disc repair. I've done fusions for years. I've cured people's back pain with spinal fusions, but that's a big, bloody, messy surgery with screws, rods, cages, long recovery. You're on opioid painkillers for months, like 3-6 months, just taking painkillers, just getting over the pain from the surgery. Not the back pain, pain from the surgery. So when we started doing the laser surgery, people weren't having any back pain afterwards. They'd have just a little discomfort for one night. We realized they didn't even need the opioids anymore. So our laser patients don't get any painkillers except Tylenol and usually one or two Robaxin. So you did it. You happy you did it?
I'm very happy.
Yeah. And you can see in the surgery that we did, we actually got into your disc. We used the laser to clean up those tears at L4-5 and L5-S1. Surgery went really well for you. We didn't have any problems. It was just a tiny Band-Aid incision on your back, and that's why you went home an hour later, and that's why you're here today ready to go home. Where are you guys heading back to Virginia?
This afternoon.
Driving?
No,
Flying?
we're flying.
Flying out of Orlando?
Orlando.
Awesome. Anything you want to say to your friends and family and people you know out there?
Yes, living in pain is hard. It's not a way to live. And I recommend Dr. Deuk any day.
Well, thank you. I appreciate that. You had faith, and you're going to be rewarded for that. Congratulations.
Thank you.
All right. Good to see you. Good morning. I'm Dr. Deuk at the Deuk Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Deuk laser disc repair. We performed that 12 hours ago. And here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics, killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us. And here I am without the patient. We cut the interview short, the testimonial, so I could answer your questions. We have a lot of questions. We just completed the Deuk laser disc repair on a patient who had multiple back surgeries done in Pittsburgh, and they were gearing him up for multiple more. He even had a fusion done with screws and rods and a cage. And of course, he's now having what's called adjacent segment disease. Adjacent means next to, segment means the next disc or joint. Disease means there's a problem causing symptoms. In his case, because he's fused at L5-S1, he also has sacroiliac joint pain on both sides, and he had the two discs above his fusion had blown out, and we went in and just repaired them. We confirmed that they were indeed the cause of his pain. He had 10 out of 10 pain at L3-4, and he had 9 out of 10 pain at L4-5. So we confirmed that indeed those are causing his back pain. And the way discs cause back pain is through discitis, which is inflammation of the disc, specifically in the back of the disc, the posterior annular tear. That's what we discovered at Deuk Spine Institute. We're the first to discover it. The reason why people have so much back pain is not from a pinched nerve, has nothing to do with a pinched nerve. The reason people have sciatica has nothing to do with a pinched nerve. It's all due to inflammation of the disc, discitis, or the nerve root, radiculitis, which causes sciatica. All right, let's take our questions.
First question comes from Darren on Facebook. And Darren asks, do larger pieces cause problems while removing them?
So the question is, do larger pieces of disc herniations cause problems when we're removing them? Actually, no, because they're being guided out that tube, so the tube is kind of protecting everything around, so you're not risking damaging anything. It's actually, to be quite honest with you, I like larger pieces because it makes my job a little bit easier rather than zapping away. If you go back and watch some of our surgeries, you'll see that patients that have smaller herniations, like many of them, they're all stuck down to the annulus, and I got to laser each piece off, and it's just tedious. We may hit that disc with 45 joules of energy, whereas with somebody with just a few herniations, we may get 20, so or less, even 18. So basically, the more pieces of herniation, the more time it takes to laser them away.
Next question comes from Gary on YouTube. And they ask, can you speak on the consistency of the nucleus pulpus? Is it jelly, or more solid? What keeps it from leaking back out after you repair?
Yeah, we get this question a lot, right, Sanjay? And so Gary on YouTube is asking us, talk about the consistency or texture of the nucleus pulposus, which is the jelly you all read about in the middle of the disc. Listen, I'm just as guilty as the next person calling it jelly. That's how I was brought up. Obviously, it's not jelly. So, in my opinion, the best way to describe the consistency of the nucleus pulposus is that of a uncooked shrimp. Now, I've thought a lot about this over the years. I mean, we've gone from crab meat to, it looks like crab meat sometimes, but the texture is not really that of crab meat. It's more of, normal nucleus has more of a texture of a nice fat shrimp that's uncooked. It's squishable, it's got a lot of water in it, and if you push it hard enough, you can break off a piece. And that's what a herniation is. So, yeah, uncooked shrimp. That's my best description. That's why it doesn't just leak out the tear when we're done. By the way, when I'm done, that tear is about 3 millimeters. And so getting a shrimp, uncooked shrimp out of 3 millimeter tear, it's about that big. It's pretty hard to do. So you're safe unless you go lifting heavy things. That's why we give our patients restrictions.
Next question comes from Juan on YouTube. And they ask, by fixing a bulge with the laser, would that stop the disc degeneration, or would the degeneration will continue until a disc replacement is needed?
That's a great question. So most 99.999% of doctors have no clue how to answer this question because they don't know the answer. Degenerative discs come from inflammation in the annular tear. So by cleaning the annular tear like we do, that should stop the inflammation. It stops the degeneration of the disc. The problem with other types of surgery like microdiscectomy, discectomy, laminectomy, is the surgeon is not cleaning the tear. He's not getting rid of the inflammation. That's why people have recurrent herniation and they have back pain afterwards, because he never fixed the problem.
And then lastly, we have a question from Wizzy or Wisey, excuse me for pronouncing that wrong, from YouTube once more. And they asked, is rotary torso machine exercise helpful for a bulging disc at the L4 to L5?
So the question is a rotary torsion machine exercise good for a bulging disc at L4-5?
Yeah.
Folks, it's real simple. We broadcast because we want to answer your questions. We want to empower you with knowledge. If you have a painful disc herniation, there is no exercise on earth. There is no chiropractor, no physical therapist, no massage therapist. There is no injection. There is no pill that will take your pain away from that herniation. Now your body may heal it a little bit, might feel better for a little while, but as soon as you get active again, you're going to re-injure it, it's going to be painful again. The only treatment in the world, there's two things. It is the fusion of the disc or the Deuk laser disc repair. That's the only way to get rid of pain that comes from a herniated, bulging, degenerated, ruptured, protruded, extruded, slipped disc. That is the main message here. If you put off the laser surgery, you're just going to let the disc get worse, and you're going to eventually come back, and that when you come back, your disc will be destroyed because you waited too long. We can still fix it and get rid of the pain, but your disc will be destroyed. It will not be the normal height. It will not be the normal appearance. It will be collapsed. It'll still be painless after I'm done with it, but it'll be destroyed.
We just got 2 extra questions. This next one comes from Edward on YouTube. And
Hello, Edward.
They asked, what is the main reason for the SI joint rhizotomy over injections?
Well, great question. So when you have a painful sacroiliac joint, there's nothing wrong with doing an injection first to see if that will take the pain away and keep it away. The problem with injections is they wear off and then people come back with the same pain. And they have to keep getting injections 2 or 3 a year for the rest of their life. That's a lot of injections of steroids and a lot of procedures. So the reason to do the Deuk plasma rhizotomy, which is a permanent elimination of sacroiliac joint pain, is to avoid having to come back for years and years and years getting shots done in your SI joint. We've done SI joint treatments for 20 years. And before we did the Deuk plasma rhizotomy, which we just started doing this year, for 19 years, our patients would have to keep coming back and keep getting shots. And we would send them to therapy. The therapy would help a little, but eventually, as soon as they got active again, they're going to aggravate the SI joint. It's going to rekindle the pain, and they're going to be getting shots again. So it's a vicious cycle of pain, inactivity, shots, activity, pain, inactivity, shots, activity, pain, and it just goes around and around and around, and it doesn't help anyone except for the pain management doctors. So if you want to permanently get rid of SI joint pain, you do the Deuk plasma rhizotomy. We'll go in and we'll deaden the pain nerves to the SI joint, right along this area.
And then lastly comes from Juan once more on YouTube. They ask, can you repair hip labrum tear debris with the Deuk laser treatment?
Great question, Juan. Can we, so what can we do for the hip labrum tear? Yes, we can get rid of your hip pain with the Deuk plasma rhizotomy. If we get rid of your hip pain, will that repair your labrum? No. No, if you want to do a labral repair, you have to do arthroscopic or open labral repair. We don't do that at Deuk Spine, but the reason we don't is we don't think it really has a long-term benefit to patients. We think people end up continuing to have problems and pain. So why put somebody through a procedure that's not going to work long-term? So with the Deuk plasma rhizotomy, we can kill the pain to your hip. You can start moving your hip normally, and a lot of times the labrum will actually find a way to heal, and it's painless. So you can still get out and do everything you want to do without having to have open surgery of the hip. If you're interested in the Deuk plasma rhizotomy for hip pain, knee pain, or even shoulder pain, contact us, set up an appointment with Dr. Patel here at Deuk Spine, and we can evaluate you whether you're a candidate for the Deuk plasmorhizotomy for your hip, your knee, or your shoulder.
And that is it.
Have a wonderful day. We'll be back in about 30 or 40 minutes for our second surgery. This lady has had back pain and now bilateral sciatica pain from the L5-S1 disc. She has an L5-S1 herniation on both sides, and it's pinching the nerve roots on both sides and irritating them. So she's from Vietnam, and she's had this pain since she was a young girl in Vietnam for about 20 years. And now she's here to get it fixed. We'll be back